All right. Welcome everyone to another virtual shouting at session at Hearts for Health. We're happy to have you here. Hopefully your week has been going well. We're quite a ways into the summer now, almost late June. Can't believe that. The month has passed by pretty quick. But today we're joined by Dr. Malhotra. He's here to talk about sleep medicine. For a little background on him, and he's going to provide a little more context about the specialty and who he is. But just a little background on him. He's the Fellowship Program Director of Sleep Medicine at Washington University in St. Louis. And he was the 2021 to 2022 president for the American Academy of Sleep Medicine. So he's definitely been very involved in the specialty. I actually worked at a sleep lab, so I'm very interested to listen into this session. And I think this might be the first time that we hear about the specialty too. So I'm sure it's very exciting for everyone listening in to hear. Just a few reminders though, before we do get started with the presentation, especially if you're new. So we do have a Q&A at the very end of these sessions. If you have any questions for Dr. Malhotra, feel free to type them in the chat. I'll read them out at the end of the session, or at the end of the presentation, I should say, with any time that we have left, and I'll go in the order that we receive them. So again, at any point in time, if you have any questions, feel free to type them in the chat. And then another thing is we do have these sessions twice a week on Mondays and Thursdays. So if you are interested in joining in on more of these sessions to hear from more speakers, we do have sessions from physicians, from PAs, from nurse practitioners, really from every kind of healthcare professional. And that means that if you're a pre-med, a pre-PA, a pre-dental student, we have sessions for you. If you'd like to stay tuned with those sessions, we have two ways that you can do that. Our Instagram page, which I'm sure is how most of you have heard from us. And on there, we post flyers. We do have a few extra flyers for our other programs. For example, later on in this summer, we'll be releasing our mentorship program, another cycle of mentorship. And we have a few volunteering programs that y'all will hear about through our Instagram page. And then the second way you can stay tuned with us is our email listserv. That email listserv is a weekly email that we send out, again, with our flyers and with extra opportunities. The only really real difference is that it's an email. And to sign up, you can hop onto any page on our website, go to the very bottom, and you'll see a subscription form there. We have your name, your email, enter those in, and you'll be good to go. Again, those are just two ways that you can stay tuned with us for more of these sessions if you'd like to hear more about the specialties and the speakers that we have. But I don't want to talk too much. Those are all the reminders I have. If you do have any questions for us outside of what I mentioned, please do feel free to contact us over email. Our email is community@hearts4health.org. And we can answer any questions that you have about virtual shadowing or any other programs that we have here at Hearts for Health. With that said, though, Dr. Malhotra, feel free to take it away.
Great. Thank you so much for the invitation. And I am very excited to share my journey, but also sleep medicine to the group here. I think besides the fact that maybe we can recruit some people into the field of sleep medicine, I think it's important to learn about sleep just for your own health or your other family or friends' health. So I think hopefully that this will pertain to whatever type of field you're going into, that you'll see sleep can definitely play a role. So I'm just going to start off with my journey, and then we'll kind of move on to some other things in specific to sleep medicine. But I grew up in St. Louis, Missouri, which is where I live right now as well. I didn't go too far away for my undergraduate in medical school. I enrolled in the 6-year medical program, which is a medical program straight out of high school. So I was very interested in medicine throughout my high school years. And though I did not have anyone directly in medicine in my family, my older brother was in medical school at the same place. And so I was pretty familiar with the program. And the program was in my state, of course, being in Kansas City, right across the state from Missouri, or from St. Louis. And that program really fit what I was looking for, because I knew I wanted to be a physician. I know I wanted to go to medical school, and this was allowing me to kind of skip that step of having to apply for medical school later. And what I really liked about it was that it would actually allow us to start seeing patients and do medical school classes early, because I was really eager to get started with that. So for me, it worked out great. It's not a program for everyone, obviously, and a lot of people probably need some time to decide what they're doing. It just for me, it worked out great. So I spent my 6 years there. And after medical school in Kansas City, I decided to do a neurology residency. And I matched at University of Michigan in Ann Arbor. It's a school that I like for a lot of different reasons, not just a neurology program, but I looked at it even for undergraduate, and had always been a fan of the school as well as their sports teams. And so I was really excited when I matched at University of Michigan. And that's a 4-year program. So usually after medical school, you'll do 4 years of adult neurology residency. And one of the subspecialties that you can choose to follow after residency and do a fellowship is sleep medicine, where I was exposed to that during my time in residency. And I'll get a little more into that as they talk about sleep medicine, but that allowed me to do a sleep medicine fellowship there, which is a one other year after my residency. And then I was finally finished with training at that point. And then I stayed on at University of Michigan as teaching faculty, doing both neurology and sleep medicine for 3 years. My wife, who is also a physician, was still completing her training. And so we're kind of staggered. So it made sense to kind of stay put. And I enjoyed my time at Michigan anyway, but we eventually wanted to move back closer to family, which was St. Louis. And so I moved to St. Louis University, where I, again, did a very similar role of neurology and sleep medicine in that medical school, where I was mainly seeing patients and doing clinical activities and teaching. And then in 2018, I moved just a little about 5-10 miles away to Washington University in a similar role as well, doing mainly sleep medicine, but also some neurology as well. And that's where I'm currently at, is at Washington University in St. Louis School of Medicine. What I thought I'd talk about first is kind of just what does my normal day-to-day schedule look like? So like I mentioned before, I'm mainly clinical, so I actually have very little time dedicated to research. I do have some time dedicated to teaching that I'll talk about, but most of my time, if we had to look at actual percentages, probably 3/4 or 75% of my time is spent seeing patients with sleep disorders, adult patients. And so some of that time is reading sleep studies that were done overnight that I will review the next day or the day after. We'll talk a little bit about that in slides in the coming up. I also see patients who come in with sleep complaints. Maybe they're not able to sleep at night. Maybe they feel real sleepy during the day. Maybe they have weird movements or sleepwalking or punching or kicking in their sleep or seizures in their sleep. Those are some of the complaints that I'll see in my outpatient clinic. I do cover some inpatient neurology time at the hospital. And so as being faculty at the School of Medicine, one of my responsibilities is to take my turn on the inpatient neurology service, where patients with a variety of neurological complaints will come into the hospital, whether it's seizures or headaches or mental status changes or weakness or numbness or tingling. Those are some of the things that we'll see in the hospital. Along with things like strokes as well. And then part of my time, besides seeing patients, is teaching medical students, residents, and fellows. And actually, I do direct our sleep medicine fellowship. I mentioned to you, I did my fellowship at University of Michigan. So it's a 1-year fellowship that we offer at Washington University as well. And much of my time in regards to the fellowship is obviously making sure our fellows are getting the proper education, helping with their lecture series and their conferences, making sure they're assigned to different faculty members for different half days, making sure that they get ready for their boards that they'll have to take once they finish their fellowship. Making sure they hit all their milestones as far as how to take care of all the variety of sleep disorders. And sleep medicine fellowship is kind of interesting, as we cover both adults and kids. And so I work with my pediatric counterparts to make sure they get a good experience at St. Louis Children's Hospital as well, in their sleep center to see kids. And then part of the fellowship director job is also to recruit. Since it's a 1-year fellowship, where kind of once we recruit people, which is usually over the summer, and then we find out who we match for the following year in December. Once they arrive in July, it's almost time again to start to recruit for the next year. And so part of that is, looking at applications and interviewing and then ranking our applicants for our sleep medicine fellowship as well. So part of that job is just recruitment as well. And then one other hat that I've worn over the last about 8 years is I was on the board of directors for the American Academy of Sleep Medicine, which is a medical specialty society or group, mainly based in the United States, although it does have international members. made up of sleep medicine providers from, again, across the world, but mainly the United States. And so I was on the board of directors of the AASM and had the privilege of serving as president in a couple of years ago as well. And I just rotated off the board here about a month ago. And so the AASM is made up of almost about 10,000 members from, again, across the world, but mainly the United States. It could be physicians like myself who practice sleep medicine. It can be physician assistants, sleep technologists, respiratory therapists, EEG technicians. It can be dentists. A lot of dentists provide treatment for sleep apnea with dental devices. Psychologists who can not only see a variety of sleep disorders, including insomnia, and a whole bunch of other specialties too. So one of the fun things about sleep that we'll talk about is that it really does encompass a lot of different specialties, a lot of different professionals, a lot of different staff that are all part of the sleep team, which makes it really fun. I like interacting with people from different backgrounds, different levels of training, and different expertise to try to take care of patients. And that's what really drew me to sleep medicine. Wanted to talk a little bit about neurology just because that was the path I took to get to sleep medicine. But I'm going to focus mainly on sleep medicine since that's what I was asked about. But I was fascinated with neurology in medical school. I was not necessarily, I did not know I was going to do sleep medicine in medical school. So that came later in residency. But when I was in medical school, that I wasn't exactly sure what I was going to go into, but it became pretty clear during my rotations that I really liked fields that were kind of detailed oriented and methodical and kind of making lists of possible differential diagnoses that a patient can have and then kind of marking them off based on different tests and then kind of doing another run of tests and then trying to figure out where it is. So kind of like detective work. And I wasn't really into something really kind of quick and easy, and I shouldn't say easy, but quick and fast. Like some fields are, and really the procedures where I'm doing it with my hands, like surgical specialties, wasn't something that was as interesting to me, although I definitely knew that they're very important. And so neurology really fit that nicely. And really, when I looked at kind of different organ systems, I thought, okay, well, internal medicine, maybe neurology. The brain just really fascinated me. I thought it was definitely a big unknown. And it's still a big unknown, and that's what I liked. It was exciting to know of all the as many questions as you can ask about neurology, and not have the answers necessarily. I was comfortable with that, which that's one thing that I think if you go into a field like neurology or sleep, you have to be kind of comfortable with the uncomfortable of not knowing all the answers. And but it's so exciting when we do find some discovery about the field. It's so some of these major landmark things we learn about sleep or neurology are just recent. And so it's really exciting to be kind of living history as we learn about and kind of unravel the mystery of the brain or of sleep. And so that's really what drew me to it, along with just fascination with how our clinical exam and history was used to kind of evaluate what happens in neurology. So I really enjoyed that aspect of it. What drew me to sleep was during my neurology residency, we rotate through our sleep clinics and we do a little bit of time reading sleep studies, and University of Michigan has a really large sleep program. And so I think that probably also had a part in having me interested in sleep medicine as I rotated through. But it was a kind of even more of a mystery than the brain. And what I have listed here is sleep is a third of our lives, right? So we spend a large portion of our lives sleeping. And really, if you look at someone sleeping, or even if you read about sleep in the medical literature, if you go back to kind of the early 1900s or even the mid 1900s, and maybe even in the late 1900s, kind of thought of it as a passive state, where maybe nothing's going on. We're kind of just everything's turned off and resting for the night. But actually, when you start to measure things, though it looks different than wakefulness, it's still very active. Sleep is a very active process, and that really led to quite a bit of explosion. The next slide I have is a really interesting quote by one of kind of our fathers of sleep, Dr. Russ Chafin, who was at University of Chicago. And his quote is very interesting. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made, right? So we tend to think that the body does things for a reason, even though we don't always know why. But if we're spending a third of our lives doing that, and we all know that if we don't sleep, how poor we function and feel the next day. Clearly, there's a lot of things that our body needs from sleep, which kind of proves the point that it's such an important process. What's other interesting on this picture is that you can see this doctor is kind of in front of one of the really old sleep study machines. I'll be showing you some clips of sleep studies that are obviously at this point digital. But you can see that in this case, there's all these pens on a piece of paper with this humongous machine that takes up the whole room. So if you ever look at pictures of old computers, for example, it's the same idea where the old equipment used to take up a whole room, and now, it's just a normal computer that can run it. It's interesting how time changes. Sleep also is very, very, the society in general is very interested in it. So it's not something that just, is in the walls of my sleep center. I would actually argue probably most of the discussions about sleep are maybe with sports teams and trying to learn how they can get a step up on their competition about how they travel or how they sleep before a big game. Or I have a clip here of Ariana Huffington, who's a big proponent of importance of sleep and how to make her workplace or her publication and the people working on it function best due to sleep. And then there's a whole big field of what I call consumer sleep trackers, things like Apple Watches and Fitbits and Jawbones and a whole bunch of other devices that are really trying to measure sleep at home and make you healthier and function better during the day. And all of those are, we'll call, invading our field as well in good and bad ways. But clearly there's a big push by society that they've realized that they may have been missing the importance of sleep, and now is realizing how that is really a pillar of our health, right? So we almost always think of, when we think of being really healthy, making sure we follow a good diet. And we know that exercise and activity is important to lead a healthy life. But sleep is really one of those other pillars that many times is ignored. And as a sleep medicine physician, that's kind of one of our jobs, is to make sure that we improve the patient's health by focusing on their sleep and making it as healthy as possible for them, so they can function best during the daytime. And what's interesting about sleep is that it yes, if you don't get sleep, you're going to be tired and have a bad mood and feel like you're slower the next day, possibly. And you can imagine if you're not sleeping well for years and years, that all compounds on itself. But sleep is important for almost every part of our body and every function of our body, whether it's the immune system and fighting off infection, or maybe even how you respond to a vaccine that's going to try to help you battle an infection. Sleep's important for healing after a surgery. Sleep can be important for helping your memory or thinking, or when you're studying for a test. Maybe even when you're trying to run a race or try to hit a golf ball or a tennis ball. Sleep can be important for things like memory, maybe even preventing memory problems in the future. There's some data suggesting that sleep plays a role in cleaning the brain at nighttime. So if you're not sleeping properly throughout the years, you're more likely to build up different proteins in the brain that may lead to things like Alzheimer's disease. And so those are just some of the things that sleep can touch on. And you can see that it really touches a lot of different organ systems, a lot of different parts of medicine. And that's, again, one of the main reasons that I chose sleep medicine, is I just thought it was a huge field with lots of different implications on how it can affect people's lives. And really what I would see in clinic when I was a neurology resident is that maybe someone coming in, like you could imagine, let's say a child who's having sleep problems, and their parents are affected by this, right? Because they're up all night because their kid's not sleeping well. Their school is upset at the kid because the kid may be not behaving properly or getting good grades. And then you figure out what's going on and you fix them in a rather short period of time. And then suddenly this kid turns from maybe a C student to an A student to a properly behaved kid with a happy mood, making the parents happy, making the rest of the family happy, and a productive member of society eventually. And it was that dramatic change that I would see in some of these patients just by simply improving their sleep that really got me excited about the field. And as I mentioned, this sleep medicine fellowship, which again really is not very well known even in medical schools or residencies. So it's still something that you can talk to a lot of other physicians about and they wouldn't necessarily know. It is a 1-year accredited fellowship, and you can actually enter through a lot of different ways. Obviously, I entered through neurology, so you do have to do a residency first. But you could do internal medicine residency and then do the fellowship. You could do psychiatry. You can do pediatrics, you can do family medicine, you can do ENT, or even anesthesia. So there's a lot of different ways. And again, that's the exciting part about sleep, is that you could imagine coming in from neurology like myself versus maybe an ENT doctor, how we are going to have a little bit different perspective on the patients that we see. And it makes for really interesting discussions during case conferences and journal clubs, and even just at the bedside when we're looking at patients. So a little bit about, what would I see as a sleep medicine physician? We talked a little bit about that before, but kind of my simplified way of looking at different sleep disorders, or there's a variety of sleep disorders that will make the person feel real sleepy during the day, where they're trying to stay awake, but they just can't stay awake. And then there's also disorders where actually the person's trying to get sleep, but they're actually not able to get sleep at night. They're having insomnia, maybe from their mind acting, getting real active at nighttime, or maybe even restless leg syndrome. And then we'll see patients who are just complaining of abnormal movements during sleep. Maybe they're punching or kicking or acting out their dreams and injuring themselves or their bed partners. Or maybe they're having something that looks like a seizure or sleepwalking, where they'll actually do things in their sleep and not remember it. So those are really a nice way to kind of encompass all the different sleep disorders that we see in our sleep medicine clinics. There's a formal classifications that I listed there. So there's actually over 80 recognized sleep disorders in this international classifications of sleep disorders. And the next slide, I'm just going to touch upon just some of the official names of some of these, just so you're aware of them. Obstructive sleep apnea, which is the first one listed, is by far the most common disorder that we see in a clinical setting. Although insomnia is likely just as common, what comes to our sleep centers is a lot of obstructive sleep apnea. And we'll talk a little bit more about that. But restless leg syndrome, and then a lot of the other things, I don't want to name all of them. Narcolepsy is another disorder that we see a lot in our sleep clinic, although it's, again, not maybe as common as sleep apnea. It is something that really needs to be followed by a sleep specialist. And then something else I haven't talked about yet, which is circadian rhythm disorders. And if you remember, the circadian rhythm is kind of our own body internal clock that's trying to keep us awake during the day and help us go to sleep at nighttime. Some people's clocks are off, meaning that although they need to get up for class or work at a certain time, their body's not letting them, and we have to kind of adjust their circadian rhythm to fit their social duties. What's interesting about the circadian rhythm is that in some people they're very easily able to switch back and forth to different schedules. Other people have a really strong circadian rhythm, but our bodies not only have its own circadian rhythm, but what we're learning is actually each cell and each organ has a circadian rhythm. And so although it's probably too complicated to put into practice immediately, what a lot of researchers are looking at is when should we be maybe dosing medications for something like kidney disease or lung disease or asthma? Because maybe for one person, because of their own internal clock, the medicine is going to work better at a certain time than someone else. And if we could genetically analyze different people and kind of know their clocks, we may actually be able to adjust medications to get better outcomes. And so that's kind of an interesting thing that people are working on that I think still has some work to do, but that's also captured under sleep medicine. So probably something else that people think about when they think of sleep medicine are sleep studies, or one of the official terms is polysomnography. And so I wanted to at least touch base on kind of what is a sleep study. These are, there's an adult on the upper left corner that's hooked up to a sleep study. And then you can see we do those on kids as well. And the room down below is one of our sleep rooms at our WashU Sleep Center. So our sleep center, for example, has 12 beds overnight. So we can do up to 12 people each night. And so sometimes when we're evaluating someone for a sleep disorder, we actually bring them into our sleep lab, where they'll get all these sensors hooked up on them. And we'll talk a little bit more about that to try to figure out what's going on. Now, we don't do this on every patient. And actually, as we're getting better and better at measuring things at home, which we'll talk about, a lot of this stuff can be done at home now. And so, what used to maybe always require what we call an in-lab sleep study or polysomnography may not always necessarily require that. One great example of this is obstructive sleep apnea. We used to always need to make a diagnosis of obstructive sleep apnea by bringing the patient in overnight for a sleep study. Well, nowadays, most people in the United States are measured with home sleep apnea tests. And so that's just one example, and I'll show you the difference between the two. But if we do an in-lab PSG or polysomnography, what are we measuring? Well, we're measuring things like eye movements. Believe it or not, measuring eyes can help us gauge if someone's asleep and what stage of sleep they're in. We muscle EEG or brain waves, electroencephalogram, and we look at the frontal, central, and kind of back parts of the brain. And those are little sensors that go on the scalps that you kind of saw in the picture there. We must measure muscle tone. We know that as we dive deeper and deeper into sleep, our muscles get more and more relaxed and even paralyzed at one point of sleep. And so one of the easiest muscles to measure that with just an electrode on the skin would be the chin muscle tone. We measure snoring because, of course, a lot of patients were looking for sleep apnea. We measure airflow to see if they're breathing properly at nighttime. Respiratory effort with basically like a belt that goes around the chest and abdomen. We measure oxygen levels with a sensor on their finger called pulse oximetry. We can measure leg movements with sensors on the legs. Some people will kick their legs a lot during sleep. EKG, kind of a limited EKG, but definitely to look for certain arrhythmias at nighttime. And then there's usually infrared video. So when the patient's asleep, of course, the lights are off. They have all these sensors on them, and we have them go to sleep. And the obvious question is, well, how is anyone ever going to sleep in a sleep lab with all these sensors on them? So the sensors are definitely annoying, but not painful. There's no IVs or needles. And again, we have to take that into consideration when we're testing someone, is that maybe that patient who's really sleepy, can kind of sleep anywhere, is the better person to bring into the lab versus someone who's not sleeping real well. Maybe a sleep study is not what you should be doing. So most of our patients we're bringing in are excessively sleepy, and honestly, they will get enough sleep during the night. We know it's not a normal night of sleep to come into a fake environment, but let's say, for example, they are sleeping and then they start to have cardiac arrhythmias or breathing issues. Well, we make the assumption that's likely happening at home as well. And so it really does still answer the correct questions that we're asking, but it's definitely not something that we need on every patient. And we know we're altering a lot of the variables just by bringing someone into the sleep lab. Very useful test under the right circumstances. It is a test that's covered by medical insurance in the right situation as well. And it is a safe test. So I always say it doesn't sound like fun, but it's definitely not a dangerous test. This is some of the data we get from a sleep study. So here's some of the overview of the data. You can see right on the top where it says staging, that's the different stages of sleep. So we can tell based on the brain waves how much sleep you got that night, how many times you woke up, how much deep sleep you got. Again, realizing that you're going to be a little bit different in our lab, obviously, compared to at home, but it's still interesting to look at. We'll obviously get a lot of respiratory data looking at things like oxygen levels and if they're having any apneas or pauses in breathing. We'll have a leg movement count as well. And you can see kind of the oximetry as well. And like what it's highlighting here is a lot of drops in oxygen level from someone who has sleep apnea. And then we don't just look at this kind of overview, but we'll actually get, this is a 1 minute snippet from our sleep study. And again, we typically measure people for 7 to 9 hours each night. So you can see it does take some time to go through the data. But what I wanted to show here, and I think my laser pointer will work here, is that we have our eye leads up here, and then we have our chin leads right here, and then we have our EEG leads here. These are 6 kind of leads around the scalp, looking at the brain waves. And then we have an EKG here, and then we have right and left leg sensors, and then we have a whole bunch of breathing sensors, a snore channel, a couple airflow sensors, and then a chest and abdomen effort, and then an oximeter. And so what we're doing there is that we're basically measuring all these different signals. You can see all these weird brain waves, looking for things like spindles and K complexes, which are all markers of different stages of sleep, and then measuring their breathing. But this is kind of what one page would look like. I just kind of wanted to show you the snippet, and we would scroll through this study and make our analysis of maybe what's going on with the particular patient. And I do have some cases at the end, so we'll kind of maybe show you some examples of what we would do with the sleep study. But we do home testing as well. So especially for sleep apnea, you can measure breathing at home with, you can see these different examples of some of the home sleep apnea tests, including the one in the lower right corner that is just a simple disc on your finger that can measure breathing and sleep. And something that you would actually Bluetooth to your phone, and that would send all the data to me to review. And it can even send up to 10 nights of data. That's how much that battery will hold. So things are getting better and better and better as far as getting more data from home, probably more accurate too, if you're in your own bed versus in my lab, and definitely cheaper and more convenient. So that's really exciting about sleep medicine as well. Okay, so I was going to go ahead and jump into one of the cases. The first case here is a 35-year-old gentleman who is complaining of snoring. His wife says that he stops breathing at night. He can barely stay awake at work meetings, has fallen asleep at the wheel with driving before. He is overweight, but is really otherwise healthy and has really no other medical history. And so you can see that I'm building a pretty good case here for someone who's kind of a classic picture maybe for obstructive sleep apnea. And I hate to do that because it makes it seem like everyone has to have all these symptoms, but women can have sleep apnea very commonly. Children can have it. So we don't want to assume it has to be a male who's overweight, but those are two risk factors for sleep apnea. And what we're worried about in sleep apnea is when someone enters sleep, the muscles all go to sleep. Just like I mentioned, that's a normal fact. And the upper airway is made up of muscle. And so some people, when they're laying down and their muscles relax, will actually have some collapse of the upper airway at nighttime, not allowing enough oxygen at night. And it'll happen only during usually really deep sleep. So the person's not going to be aware that it's actually happening. And it happens very subtle and slowly in enough time where the person's, again, has no recall of the event, but the oxygen levels can drop to dangerous levels. Let me kind of show you what a sleep study like in the patient I just showed you can look like. So very similar to the page I was showing you before, but what is highlighted in the blue here is this really long pause of breathing where there's still respiratory effort. So you'll see some wavelengths there. And I'll actually try to use my laser pointer again. You can kind of see this pause and breathing, and you can see this, there's respiratory effort here, and this is happening 30, 40 seconds in duration. What's interesting is the oxygen level just kind of slowly drops. And what happens is, you, unlike during the day, if your airway was blocked, you would immediately kind of cough and gag and end the apnea. Because you're so deep asleep, until that oxygen level reaches a certain level, your brain doesn't even know what's going on. And then it suddenly wakes up and everything normalizes, but this will happen kind of throughout the night over and over and over again. And the concern of that is, of course, besides the fact that your oxygen levels are dropping, your heart rate has to go up as your oxygen levels drop, but your sleep is also affected by this. And so someone will feel real sleepy, just like this guy that I presented, who's having a problem staying awake with driving and at work. We ask about snoring because a lot of times snoring is a sign of upper airway kind of resistance or collapse. And so when someone mentions that they're snoring, which again, people can snore and not have sleep apnea, but then also their bed partner saying that they're actually stopping breathing at night and then they're sleepy, that is definitely worrisome for something like OSA. And so sleep apnea would be diagnosed again, either with an in-lab test like this or a home sleep apnea test. And if you brought someone into the lab, this is again kind of in this case, what we measure is how often they're having a breathing problem. And this is per an hour. And so believe it or not, you're allowed to have some normal pauses in breathing, believe it or not, about 5 an hour. All of us will have some normal kind of what we call physiological or normal pauses in breathing. But once it gets to above 5, in this case, this gentleman had 45 times an hour. We do see this a lot. That's when we start to worry about obstructive sleep apnea. You can see his oxygen level drop to 70%. So kind of on this first half of the night, you can see all these lines represent all the different apneas that he had. Those are right over here. And this is all his kind of fragmented sleep. This is his oxygen. You can see it's going really far low. And then what happens is the technologist who's there overnight with the patient will actually wake the patient up and then actually start a treatment, one of which is CPAP. And then you can see that his stages in sleep start to normalize, his oxygen level normalizes. And again, we've suddenly kind of abruptly and rapidly changed this guy's kind of struggle to breathe all night to a nice even breathing that hopefully will get him really restful sleep and where he'll be able to stay awake with the activities that he needs to. And so this is an extremely common condition, probably looking at tens of millions of people around the world with it. Most people don't know they have it. Not everyone is necessarily affected as much as this gentleman. So some people may not have many symptoms at all, or maybe just have a mild degree of it. And other people can have a severe degree like this gentleman, where we definitely would not only want to do it to make him feel better every day, but also to help his heart and brain throughout his life. Obviously, they need oxygen and need rest at night as well. We talked about CPAP, or continuous positive airway pressure. One treatment that most people have heard of that is still the most common treatment is this machine that you would wear at bedtime. And so you would actually put the bed next to you, the machine next to your bed, and it would deliver basically pressure to the upper airway to keep it open, as kind of stated here. And the next slide here kind of shows a picture of what a CPAP machine would look like. They're pretty sophisticated nowadays, so they can kind of track your breathing and they can send it to your phone, as you can see here. But the idea is that you would deliver pressure to the upper airway to kind of help keep that airway open at night. Definitely sounds funny. It definitely looks unusual, and so a lot of patients are hesitant. But again, in a gentleman like yourself, where his wife obviously is worried about him, she probably doesn't care what it looks like. He needs to keep his job. He needs to not fall asleep at the wheel. If this makes him feel better, the patient's going to have no problem keeping this on at night. But it is not obviously for everyone, and not everyone, even if they want to wear it, can wear it. So it's not a cure-all by any means, but it's a safe, effective treatment for some. Although it, like I said, it can be a difficult thing to get people to wear, and that's what I spend a lot of my time doing, is kind of fidgeting with it and trying different masks and pressures. And we get the next slide's kind of looking at a whole bunch of data that we get from the machine. The machine's kind of surprisingly can capture all sorts of data from the person wearing the machine, things like usage and if the breathing events are gone. So it's kind of cool that they have all these features on the machine, but like I said, it doesn't matter if the person's not wearing it. And again, with treatment, what are we trying to make someone? Well, we're trying to improve their alertness, their wakefulness, their cognition, their mood. I mean, you can imagine almost anything can get better. I have a picture of Shaquille O'Neal had sleep apnea. He's someone that is a big fan of that, but we get a lot of happy patients, and we get a lot of patients that can't wear their CPAP. There are other treatments, and I don't want to talk about all of them, but just so you're aware, it's not CPAP or bust with these patients. Dental devices can be made by basically kind of moving the lower jaw just a little forward during sleep to keep the airway open. And so you can see those would just be something you would put in your mouth. Here's a picture down below here where it kind of shows how the chin moving forward would help keep the airway open. And this is one of the ways that dentists get involved in sleep medicine. There's even a new device called the Inspire device that's a stimulator that will, maybe you'll see ads on TV for, because they've been putting ads where you just use your remote control to turn on a sensor that will basically stimulate the tongue during the nighttime to keep the airway open. So that involves a surgery. So it's not that easy to do, but it is another treatment. So just some of the things that people are working on, and that there's many other treatment options that are on the horizon as well for this very common condition that, like I said, I spend at least half my patients I see have sleep apnea on the adult side. Let's move on to another patient case here. This is a 58-year-old man who reports spells at night of acting out his dreams. He's punched a wall, he's fallen out of bed. He remembers having dreams that kind of correlate with his movements. So for example, he may mention that he's like fighting someone who's trying to attack him, and he'll even yell out their name and then punch the wall. And then, of course, he'll wake up and his wife will say, "What were you doing?" And he'll remember the dream related to kind of the vocalizations and the activities that he's having. I do have a video here. It's not him, and it's a publicly available video. Of course, I would never show anything that's private patient data. This is from a textbook, kind of our most important textbook in sleep medicine, called Principles and Practice of Sleep Medicine. We'll see how lucky we are to see if the video actually works or not, because usually we don't get too much success with the video. So if it doesn't work, then and let's see, I think if I click on it, there we go. Whoop. May not have the audio, which isn't really necessary, although he's yelling in the sleep. But you can definitely see the movements, and you can see he's in a sleep lab room getting that polysomnography done, like we mentioned, and they were lucky enough to capture it. And you can see he's trying to ward off something that's attacking him. And you could see how, depending on what the movements are, they could be quite dangerous, right? Whether if there's someone next to you, it could be very dangerous. You could injure yourself. What if you had a weapon next to you? What if you picked up a lamp and threw it somewhere? So you can imagine it doesn't take more than one episode to kind of have them end up in our sleep clinic because of a severe injury, whether it's a broken bone or a serious injury that required surgery. I've seen many different things. And so what we're looking for there on this sleep study is what we call REM sleep behavior disorder, or RBD. And the finding that we would see on a sleep study, I had mentioned to you that as we dive deeper and deeper into sleep, including rapid eye movement sleep or REM sleep, which is when we mainly dream, our muscles are supposed to be essentially paralyzed during that stage of sleep. There's actually a signal that's sent down all the way from the brain through the spinal cord to basically make the muscles relax and not move at all during dream sleep. So not really exactly clear why that would be happening, except for maybe to avoid this. Now, of course, we do have some muscles that still work, including the diaphragm, so we can breathe. And then for some reason, the eye movements, hence why it's called rapid eye movement sleep. But in people with this RBD, that signal is not being sent properly. And so while they're in dream sleep, they will actually start to act out their dreams. And what you can see on this slide that I have here is lots of muscle activity, even though they're seeing these rapid eye movements up here. And we would like this to kind of normally would be kind of very silent and blank, but in this case, this person's moving around and having all sorts of muscle activity. And so this would be a case of REM sleep behavior disorder. And the reason I presented this, not only just to kind of show you some of the unusual things that we'll see during sleep, but it's actually a window into a future medical condition. And so what we've noticed is, why would a patient like this, who's 50 something years old, start to suddenly not be able to keep his muscles under control during dream sleep? And it's makes you wonder, is there something wrong with the brain, right? And actually what we find out is that most of these patients over time, and literally maybe 5, 10, 15, maybe even 20 years later, may eventually develop something like Parkinson's disease or a disease related to it. They have a very, very high rate. You can see here, they're 50% chance of developing Parkinson's in 12 years, which is obviously very, very high. And so we think that this dream enactment is literally the first sign of neurodegeneration or damage to the brain from very, 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 very early Parkinson's. And one of the symptoms that people can present with even decades beforehand is this dream enactment. Not always, so we have to sometimes figure out why is it happening in someone, but it's definitely something that we'll start to look out for once someone like this gentleman presents to clinic. And so the reason I use that as an example is it's another really good example of how sleep is kind of showing you a window into another medical process and can be used as a marker for early Parkinson's. Now, interestingly enough, in a patient who has this, we don't know how to stop Parkinson's disease. We know how to treat the symptoms once someone gets it. But we actually don't know how to stop it. So these are the groups that are being tested now with different medicines and agents and lifestyle modifications to hopefully figure out how to stop it. So at some point, we could actually go to this gentleman and say, oh, you're at really high risk of getting Parkinson's disease, take, this vitamin or this medicine to prevent it from coming on. But at this point, we don't know enough about it. I mentioned that something like sleep medicine's in its infancy, and so is neurology, but it's still kind of an exciting finding and research topic to learn about. And so I thought I'd share that with the group. So that was my last case. So I'm going to go ahead and just put my contact information there and see if there's any questions from the audience.
Well, first of all, thank you so much, Dr. Malhotra, for going through this specialty. Like I said at the beginning, this is one that I've been involved with as a sleep tech, and it was something that I worked in the past, and this was definitely a great rundown of the specialty. I'm sure it might be new to others, and it was definitely a great introduction to it. So just to start us off, the first question is about what you sort of touched on a little earlier, how this has been somewhat of sleep medicine and neurology too, like you said, has been somewhat of a new and emerging specialty, one that's still advancing. What are some of the modern examples of advancements in sleep medicine in specific, particularly with how to make it more of a normal night of sleep, right? Because I'm sure that introduces a lot of variables when you have all these wires in.
Yeah, and I think one of the advances that I sort of touched upon is our ability to measure sleep at home. And so if you do go back to the beginnings of sleep medicine, they only could do the measurements in the lab, maybe for a night or two, maybe 3 nights. It's very costly, very inconvenient. You can imagine not everyone lives next to a sleep clinic. So if you're out in maybe a rural community, you don't even have the opportunity to do it. What if you're taking care of a child or a pet or, so you can see how that is really limiting, besides the fact that you're not even seeing the home. And so now there are literally, devices that may not even need to be touching your skin. They can be built into the bed that people are starting to explore. I would say they still haven't hit kind of our clinical setting yet, but they're just right on the cusp where, we would get maybe night to night readings of your sleep. I don't want to say for free, but kind of as you buy this device in your bed, that you would be able to share with your medical provider. So you'll know exactly how much staging of sleep you get, what's your oxygen level, your heart rate, even things like Apple Watches already measure some of that. And they're getting more and more accurate. So I think the advances is going to be, we're going to have all this data of, millions and millions of people that we've never had before to look for patterns. So right now we've had just kind of a very minimal amount for the people who are lucky enough to be next to a sleep clinic. But what if we could tell, I mentioned Parkinson's disease and finding a sleep pattern that kind of led to the risk of that. Well, what if we could figure out, this type of pattern leads to cancer or leads to, autism or leads to, what I think is going to be exciting is looking at different patterns and using things like artificial intelligence to analyze them, right? All these different signals coming from people at home, figuring out patterns through artificial intelligence and identifying kind of who needs to be identified. Now that's the identification. I think the question was asking, well, how do we fix it? And I think that's going to come later. I think we're still in the infancy of that. We've definitely had lots of new sleep medicines to help with things like narcolepsy. And I mentioned things like sleep apnea or even insomnia. There's a whole bunch of medicines, but I think that we have a ways to go on the treatments. But even with the insomnia medicines, there's been 3 or 4 new medicines just in the last 5 years to get you to sleep better. There's, believe it or not, 3 or 4 new medicines for narcolepsy in the last 5 years as well. And so we are learning a little bit more about how the brain is supposed to sleep and they're supposed to stay awake. And so that I think that's kind of where we're headed.
Actually, the next question was just about that. You mentioned the Apple Watch feature. They were asking about what are your thoughts on how accurate it is, and is there a possibility that that sort of technology by Apple or by a major technology company like that might be integrated into an at-home sleep study in the future?
Yeah, I think they're definitely starting to merge. I would say as we currently stand, a lot of the consumer products like the Apple Watch, but a lot of the other ones out there really don't go through a lot of rigorous testing. Doesn't mean that they're wrong. And I just can't say with like a medical trial to say, oh, this is, as good as what we're testing. But it's pretty easy to do, right? You could take an Apple Watch and do a sleep study. So people have definitely done that outside of Apple, meaning on, an independent researcher. And what we notice is that it is using some of the same technology that we would use in our lab tests. So what almost all of the watches and Fitbits are doing is they're measuring activity, so motion, right? And we know our devices can do that pretty easily. And then they measure things like heart rate and even oxygen levels. And what's interesting is we know that when you're asleep, you tend to move less, right? And also your heart rate tends to go down and you tend to have a little bit lower oxygen levels. So it actually makes sense that their device is probably reasonably accurate in a healthy sleeper. The part where it starts to get tricky, though, is what if you had something like REM sleep behavior disorder where you're moving a lot during sleep? Well, that device is going to think you're awake, right? Or what if you had sleep apnea and your oxygen level starts to drop because of that? Well, it's not going to know what to do with that. So I think for a healthy sleeper, it probably works. But I think the more sleep disorders you have, the more it's going to be tricked, right? Because then someone's going to have to look at that data to kind of figure out what's really going on. And then what I'll say is that, they're clearly much cheaper than the devices that we use in our lab. I mean, by like a 10th or 100th of the cost, because I mean, the sleep studies can, the equipments are thousands and thousands of dollars. And so not surprisingly, ours will be more accurate because they're just not practical to put into an Apple Watch. No one's going to buy an Apple Watch for $10,000. So they're good. They're just not there. Like everything in life, there's definitely science behind them. I think they're getting better. Things will get cheaper over time, but right now they're just not equivalent to what we're measuring. But I think for one of the best uses of these consumer trackers are trying to make sure you're getting enough sleep. So I think maybe a relatively healthy sleeper who's just wanting to make sure they get enough sleep at night, which usually for adults, it's 7 hours or more. It's a good way to kind of track your sleep because, we kind of think we're always doing the right thing about, exercising enough and eating, not that many calories, but until you start counting, you don't really realize it. So I think the trackers are really good for that sort of feature, but I wouldn't use it to diagnose anything yet.
The next thing is about BiPAP. You mentioned, and you kind of went through what CPAP looks like, how it offers a treatment option. What about BiPAP? How does it differ with CPAP?
Yeah, and so CPAP, which stands for continuous positive airway pressure, and BiPAP, which is bi-level positive airway pressure. Really, the main difference is a CPAP would be set at one setting, which goes by kind of a pressure setting of centimeters of water. So let's say like 8 centimeters of water. Well, a BiPAP setting is going to have one on inspiration and one on expiration. So you'll have one pressure when you're breathing in and then a different pressure when you're breathing out. So maybe instead of being at a CPAP of 8, you would have maybe a BiPAP of 12/8. And so the reason is, why would you need that? Well, some people may have problems breathing out against a certain pressure setting. And so the BiPAP machine for their sleep apnea may allow them to be a little more comfortable. For someone else, it may actually help move their air. Maybe they have another medical condition like emphysema or asthma or some other weakness of their muscles. And so instead of just a constant puff of air for sleep apnea, they actually need almost something to ventilate them. So you'll use BiPAPs, and even in situations in the hospital, for example, who's someone who's has like an infection or something like that. So BiPAP can be used for a lot of different things besides sleep apnea. For sleep apnea specifically, it's there really just if someone doesn't tolerate CPAP, sometimes they'll be able to tolerate BiPAP.
Our next question is about melatonin. What are some of the pros and cons that you've seen with taking it?
Yeah, it's a great question. And melatonin is a natural hormone that our body produces, the pineal gland, which is right next to the brain there, that will actually release it right before we go to sleep. I kind of think of it as a table setter for going to sleep. And so all of us will release melatonin. And interestingly enough, the signal of when it should be released is when we stop getting light entering the eye. And then it starts to, there's also a circadian component to it too, our internal clock. And so it'll release it, and then it kind of sets the table. So getting to the question, if you take melatonin, that you buy at the pharmacy in the kind of the supplement aisle, you can kind of mimic that table setting property, especially if you're trying to change the timing of your sleep. So jet lag or a shift worker or someone whose clock is off. But most people, I think, use it just to help them sleep, meaning they're just having insomnia. And it can help with kind of getting you to get sleepier, but it's really not its main strength. And so what I would say is that it's safety-wise, it seems to be reasonable. And if it's working for someone, I think that's not a bad thing to use, and we do use it. But there are definitely other strategies, like finding out why you're not sleeping. And, is it restless leg syndrome? Is it sleep apnea? Is there a circadian rhythm problem where we can kind of manipulate it? So if someone really is having problems sleeping at night and it's kind of happening regularly, and, it's unlikely the melatonin is going to work forever, it may make sense to see a medical provider, but I'm not worried about the safety of it. And I think compared to a lot of other things that people can use to go to sleep, like alcohol, which is not a good idea, or other illegal drugs, I think melatonin is definitely one of the safer ones.
Mm-hmm. That is definitely a great point. Another thing is, and you touched on there being stages that a polysomnogram can measure, the eye movement specifically, helping distinguish between those. So we know there's REM. Could you go through how many other sleep stages there are outside of REM, and what makes each distinct when you're looking at a polysomnogram? Or what are aspects that make each distinct?
Yeah, and so obviously if we go from wakefulness, the first stage that our body typically goes through is stage 1 sleep. And that's anything that's not REM, we call non-REM. So it's kind of non-REM stage 1. And that's basically just the slowing of the brain waves that we see to a certain degree. And that's kind of the hallmark of when we know someone's getting drowsy, is just the frequency of the brain waves start to slow down. The next stage of sleep is stage 2. And the hallmark of that is not only is there that slowing that we see in stage 1, and so it almost always comes after stage 1, but we'll start to see something called K complexes or spindles. And probably the best way to know what those are is to look on the internet and just see a picture of them. But they're kind of just characteristic features on the brain waves that we see. Really don't know much about them as far as why we have them or why they look like that. We just kind of know what they look like. And we know where they're coming from, which is the brain. And that's the second stage, stage 2 sleep. And then there is another stage of sleep called stage 3. And that's where the waves get really, really slow. We kind of call that delta waves because that's the frequency. They look like huge undulating waves. Sometimes it'll be called slow wave sleep. So it kind of goes by stage 3 sleep, slow wave sleep, or delta sleep. Those are all the same thing. And then in some parts of the sleep medicine world, there'll also be stage 4 sleep. But really clinically, we just kind of call stage 4 and stage 3 the same thing, which is stage 3. So I'll just stick with kind of our clinical thing. And then there's stage REM sleep, or stage R, sometimes we'll call it, which is the rapid eye movements, the loss of muscle tone. We think most people dream during it. And so to answer the question, we have stage 1, 2, 3, and REM. From a clinical perspective, there are definitely, like I said, other labs that will describe different other features, but from a clinical perspective, that's kind of what we stick with.
You mentioned that pediatrics is one way you can go through as a residency to a fellowship, and in general, there's pediatric and adult sleep studies. So is there a difference between each of those sleep studies in terms of what is monitored?
Yeah, good question. And yeah, it is interesting that at least in our field, if you do the fellowship, even from peds or an adult side, you can do, you're certified to see both. At this point, obviously, you choose to do whatever you want. But the main difference in the sleep studies at this point is that the home testing really hasn't been tested in kids. So we just don't do any type of home testing for sleep apnea at this point. It's always in the lab. That being said, the other thing in kids is we don't always do sleep studies on all of them. You could imagine trying to hook up a kid to the sleep study equipment can be even more challenging. And so a lot of times you reserve it for only the right times to do it. You may just make a clinical diagnosis, maybe like the case I presented, that first gentleman that sounded like he had sleep apnea, we still tested him. But in a kid, you may just say, hey, you know what, you've got snoring and you got huge tonsils in the back of your throat and you're really sleepy. Let's just assume you have sleep apnea and not do the study. When you do a study, really the main differences otherwise are pretty similar. They look almost exactly the same. Obviously, our labs are catered toward children, though. Typically, the rooms are a little bit more kid-friendly. There's usually a place for the parent to sleep. We obviously don't test the kids without their parents there. So there's maybe like a separate bed. The technologists are, go at a different pace, to kind of explain things further, and may even place the sensors on after the kid falls asleep. Instead of beforehand, right? So you can imagine that just let the kids sleep, and then when they're really deep asleep is when you stick all the sensors on them. And then the studies are longer. Kids can sleep much longer, especially younger kids, right? And so unlike maybe a 7 to 8 hour recording, you're looking at more like a 9 to 10 or 11 hour recording. And then really the only other thing that probably is different is that they measure carbon dioxide levels more often. And I think that's probably more historical, and some things are a little more subtle in kids, so they just want an extra sensor there. But that's really the only big difference.
And then outside of overnight sleep studies, there are a few daytime ones like MSLTs. Could you go through what those entail and why you might have that procedure for a patient?
Yeah, the multiple sleep latency test, or kind of a nap test during the day, we really have no good measure of trying to decide if someone is sleepy besides kind of asking them. And so this test is at least trying to get to that. And what we do is after a kind of a quote normal night of sleep in our lab, however normal that is, they would actually stay the next day for typically 5 nap opportunities. And so what that means is they would have 5 20-minute periods of time where they'll go back into the sleep room. We'll turn off the lights. There'll be blackout shades as well, so the room will be dark. They lay down in bed. They have a lot less sensors than they would overnight, but they still have the ones on their scalp to measure their brain activity. And we actually ask the patient to fall asleep. And so most people, when put in that dark room and in a bed, they're gonna fall asleep for at least some of, if not most of those naps. But in certain sleep disorders, for example, like narcolepsy, where we think people are very sleepy during the day, they'll not only fall asleep almost immediately, but they'll get into really deep sleep or even REM sleep during these kind of short 20-minute opportunities. And so what the MSLT is measuring is how quickly they will fall asleep during the 5 naps and how deep they fall asleep. And kind of based on those findings, we can diagnose conditions like narcolepsy.
Great answer. One last one just before we end the hour. So you mentioned that there are respiratory therapists involved in sleep studies. There's sleep techs, and respiratory therapists are sleep techs. They just fit the role better, to my understanding. But for the students listening and who would like to get involved in that type of role, what steps do they need to take? I know that there's certification. Is it possible that they can do on-the-job training? What are the routes that they can take?
Yeah, it's a great question. There's a huge need for sleep technologists and respiratory therapists. There are formal schools, and each state can be a little bit different, but I think so. Sometimes there's the kind of the details are in the state agencies, but in general, you can either get a associate's degree from usually an area community college or university, but there is on-the-job training. I think most technologists at many sleep centers, like WashU is one of them, will have programs set up where you'll kind of get on-the-job training and you'll get paid to learn. And then once you kind of get your training and go through a curriculum, you actually take a test to get certified. And so there is an exam that someone would take to get certified, but you are able to, at least with supervision of someone who is certified, learn on the job and, for at least luckily get paid and learn on the job there. Obviously, it's a really, I think, fulfilling job. You're really helping patients out. It's very interesting. I think you'd agree from some of the things I think here, it can be really interesting things that you'll see. You are working at night. That's probably one of the negatives, and at least for some. And I think it's obviously helping a lot of patients. So right now, the job markets, there's a big need for them. There's this fear that, with everything moving toward the home, I mentioned that that what will be the need of the sleep technologist, but there's so many different roles that they play, not just with testing, but helping people wear CPAP, and we'll always need tests for some of the more complicated cases.
Definitely an opportunity to think about as a student. If you have the time, definitely a very unique clinical experience. I wanted to ask because I was sleep tech for some time, almost a year, and it was definitely a very fulfilling role. But the nighttime schedule, it was a little tough at times, especially being a sleep tech. You wonder, you're helping people out with sleep, but what about your own?
Mm-hmm.
But thank you so much for these cases, for these wonderful answers. I do have one last reminder though before we do end the session, and that is for our shadowers. So if you are interested in earning credit for your attendance, we do have a quiz. That quiz is posted in the chat box, the same one that y'all had your questions in, and we also have it on our virtual shouting page. If you hop onto our website, on the top, you'll see headings, one of them being virtual shadowing. Click on to that heading and scroll a little down. You'll see a Monday and Thursday quiz. Click the Thursday quiz and you'll be guided to a Google form. It's 10 questions and you need 6 or more to pass. Once you do pass, we will send a certificate that's automatically sent to the inbox, the email address that you list. We do recommend you to list a personal Gmail or Yahoo account as your address on the quiz, just because it often doesn't filter to spam that way. But just in case you don't get it through your inbox, please do check your spam folder. And if it doesn't happen to send to either, please do reach out and we will help you track down that certificate. But this quiz will be due next week on Wednesday, June 28th at 11:59 p.m. Central Standard Time. As always, we will have another session next week, 2 other sessions next week on Monday and Thursday. And our next one will be on Monday, June 26th. Again, our regular time, 7 p.m. Central. We'll be joined by Dr. Reed. She is a double board certified psychiatrist in child and adolescent psychiatry, along with adult psychiatry. So it's been a while since we've had psychiatry on shadowing, and it's definitely going to be interesting to hear from. Again, you can follow us for Dr. Reed session and more through Instagram, where we post our flyers. Our email listserv is another way you can go about that. But those are all the reminders I wanted to wrap up this session with. Again, a big thank you to Dr. Malhotra for getting this presentation together. If we could hear some thank yous in the chat, that'd be great. But again, thank you so much for your time, Dr. Malhotra. I learned quite a bit, even being a sleep tech for almost a year. So this was definitely a great learning experience. But that is all.
Thank you.
All right. Well, I hope y'all take care. Enjoy the rest of your week. Enjoy the weekend, and we'll see you on Monday.